Again, thank you for allowing us to present our work. This is our disclosures. Okay, so a quick review again. Impedance planimetry based on a functional lumen imaging probe, FLIP, measures the dimensions and pressures of the gastroesophageal junction with the balloon catheter shown here and the corresponding hourglass image to the right, with the arrows indicating exactly where the gastroesophageal junction is. This leads to the calculation of the tightness of the lower esophageal sphincter known as the distensibility index. This has led to previous work to identify ideal distensibility ranges associating with patient outcomes. In magnetic sphincter augmentation, the mechanism to treat gastroesophageal reflux disease includes the biomechanical augmentation of the gastroesophageal junction by implanting a ring of magnetic beads around the lower esophageal sphincter. The strength of the magnetic beads in the ring ideally is weak enough to allow for food bolus transit and belching in its open configuration, while strong enough to decrease pathological reflux in its closed configuration by increasing the gastroesophageal junction resting tone. Impedance planimetry measurements after magnetic sphincter augmentation have been reported. However, outcomes have not been analyzed alongside laparoscopic fundoplication. So we aim to describe our institutional experience in performing impedance planimetry during magnetic sphincter augmentation and compare these measurements to those obtained during Nissen and Toupet fundoplication. So we included patients who underwent anti-reflux surgery and had impedance planimetry evaluations from April 2018 and June 2021. Our FLIP protocol, again, measurements were with the 40 milliliter balloon fill, no pneumoperitoneum, with the EF325 catheter, 8 centimeters. The patient-reported outcomes includes, again, reflux symptom index, GERD HRQL, and dysphagia score. So we had 27 patients who had magnetic sphincter augmentation and 100 patients who had laparoscopic fundoplication along with intraoperative impedance planimetry. For the impedance planimetry measurements, the minimum diameter and the cross-sectional area was significantly lower after magnetic sphincter augmentation versus Toupet or Nissen fundoplication. This was also seen for distensibility index, with the distensibility index of magnetic sphincter augmentation being the lowest versus Toupet or Nissen fundoplication. So the change in the distensibility index from hernia reduction to sphincter augmentation varied between operations. At hernia reduction, patients who had magnetic sphincter augmentation or Toupet fundoplication had similar distensibility indices. However, magnetic sphincter augmentation had a larger reduction in the distensibility index after sphincter augmentation versus Toupet fundoplication. Nissen patients had a higher distensibility index at hernia reduction, leading to a larger reduction in distensibility index after sphincter augmentation. However, overall, magnetic sphincter augmentation resulted in the lowest distensibility index, representing a tighter sphincter. So looking at the magnetic sphincter augmentation and Nissen fundoplication patients' quality of life questionnaire responses, such as reflux symptom index, GERD HRQL, and dysphagia score, they did not differ upon 1 or 2 year follow-up with Nissen fundoplication. So there were no differences in patient-reported atypical or typical GERD symptoms after magnetic sphincter augmentation or Toupet fundoplication. When compared to Toupet fundoplication, magnetic sphincter augmentation had a worse GERD HRQL score upon 1 year follow-up, along with worse reflux symptom index and GERD HRQL score at 2 year follow-up. So Toupet fundoplication patients also had a better GERD HRQL score than Nissen fundoplication patients. Interestingly, magnetic sphincter augmentation patients reported less gas bloat syndrome at 3-week post-operative follow-up versus Nissen or Toupet fundoplication. However, this difference was not statistically significant. So limitations of our study includes being a small sample size of patients for comparison, and with online quality of life surveys being sent on a regular basis, patients, they respond at varying rates at all time points, which can introduce bias into our analysis. And finally, you can see that we don't necessarily have objective data of GERD resolution, such as postoperative acid monitoring or endoscopy, and less clinically indicated. However, we are still collecting that because we do ask patients to return upon 1-year follow-up for routine surveillance. So, magnetic sphincter augmentation resulted in the lowest cross-sectional area in the Distensibility Index, which may be the result of the magnetic forces of the device that keeps the gastroesophageal junction firmly closed, preventing acid reflux while permitting food bolus transit and belching. The magnetic sphincter augmentation Distensibility Index is lower, which would represent a tighter sphincter. However, quality of life scores are no different than Nissen fundoplication. Thank you.